Today we will be talking about neurocognitive and neurodevelopmental disorders. Um, there is only six slides in this presentation, but I do have over 9 pages of notes that I will be talking about thoroughly with each slide. Once I finish the presentation, I will be uploading all my notes on Canvas so that you all can have a copy of what we're going to be talking about today. And essentially, it's just going over the DSM-5 for each of these disorders. So it's going to be pretty straightforward, okay? So neurodevelopmental disorders. Neurodevelopmental disorders typically present in early development. These disorders are characterized by developmental deficits that construct impairments of personal, social, academic, or occupational functioning. Typically, the range of development deficits vary from particular limitations of learning, control of executive functions, to global impairments of intelligence or social skills. These disorders frequently co-occur, meaning that if a child has been diagnosed with autism spectrum disorder, that child often has an intellectual disability such as ADHD. With these disorders, for some of them, the clinical presentation of symptoms includes deficits, delays, or excess when achieving the expected milestones. An example of this includes a child on the spectrum who shows signs of delayed or deficits in communication, behaviors that are repetitive, patterns of sameness, or restricted interests. So that was just the overview of what neurodevelopmental disorders are, but I am going to go down the list of all of these disorders in no particular order, and we're just going to talk about them a little bit and how they present themselves. So again, this is information you can look up in the DSM-5. So the first one we're going to talk about is intellectual disabilities. These disorders are characterized as deficits with mental abilities. Examples include learning from experience, judgment, academic learning, problem solving, planning, reasoning, and abstract thinking. People who are diagnosed under these disorders have impairments of adaptive functioning. So this presents itself as an individual that is unable to meet standards of personal independence and social responsibility. Typically, in one or more settings of the daily life. So examples include occupational functioning, personal independence at home or in the community. Global delay implies when an individual is diagnosed after they failed to meet expected developmental delays in areas of intellectual functioning. So usually this becomes evident as the child does not meet the requirements to do standardized testing. This can sometimes be a result of a head injury. Often neurocognitive disorders may also be diagnosed. Next, we have communication disorders. So these disorders are characterized by disruptions of normal fluency and motor production of speech, such as prolongation of consonants or vowel sounds, repetitive sounds or syllables, blocking broken words, or words produced with an excessive physical tension. They usually present in early life and may produce lifelong functional impairments. The next one is autism spectrum disorder, ASD. So people with ASD often have problems with social, emotional, and communication skills. They might repeat certain behaviors and might not want change in their daily activities. Many people with ASD also have different ways of learning, paying attention, or reacting to things. Signs of ASD begins early childhood and typically lasts throughout a person's life. Diagnosing ASD can be difficult since there is no medical tests, like a blood test, to diagnose the disorder. Doctors look at the child's behavior and development to make a diagnosis. ASD can sometimes be detected at 18 months or younger. By the age of 2, a diagnosis by an experienced professional can be considered very reliable. However, many children do not receive a final diagnosis until much older. So this delay usually means that children with ASD might not get early intervention or the help they need. Unfortunately, there is currently no cure for ASD. However, research shows that early intervention treatment service can improve a child's development. Early intervention services help children from birth to 3 years old to learn important skills. Services can include therapy to help the child talk, walk, and interact with others. When I first started gaining my hours into my practicum, I worked with a company that worked with, so I was a behavioral interventionist, a BI. And so essentially, what we did was we worked up interventions to help the child get into a routine. And how that looks is typically, so the child would have, depending on the type of intervention they need by frequency through the week. So I would visit a client 3 times a week. And so we'd spend 3 hours for those days. And we teach the child how to, anything from, learning how to use their silverware when they eat, to brushing their teeth, to picking out specific colors or numbers, depending on the severity of the child. Sometimes we required the parents' help. And so because I was an MFT, still am, but an MFT doing behavioral interventions, I would involve the parent as well. So it was almost like a family therapy, but with sorry, I was saying the ABA side of it. And it was very, very helpful because it did help the parents stay with the intervention. So we're teaching them how to do the intervention so that the child is not only getting it on those 3 days a week, but they're also getting it in between. So it was more consistent with the child. The next one we're going to talk about is ADHD. So this disorder is one of the most common neurodevelopmental disorders of childhood, usually first diagnosed in childhood and lasts into adulthood. Typically, individuals diagnosed under this have difficulties paying attention, controlling impulsive behaviors, or overly active. ADHD can overlap with disorders that are often considered externalizing disorders. Examples include oppositional defiant disorder and conduct disorder. So one of my other sites that I worked at was I was a school counselor. And a lot of the time, a lot of the, well, not a lot, but most of the kids I would see had been diagnosed with ADHD. And some of the interventions we would do with these kids was allowing them or helping them kind of identify that trigger of, when is it going to come up, when I'm going to start to feel like I want to get up and walk around the room or be disruptive. And so that was one of the things we would help kiddos out that were diagnosed with ADHD. And of course, some of these kiddos were taking medication. The next one is motor disorders. And so these disorders include developmental coordination disorder, stereotypic movement disorder, and tic disorders. Developmental coordination disorder. So symptoms include delayed sitting, walking, or crawling. Challenges with fine motor skills, writing, tying your shoes, cutting with scissors. Difficulty with gross motor skills, so hopping, standing on foot, or jumping. Typically, children with DCD present with other difficulties in association with other motor problems, which make it challenging to only make it a single factor that causes coordination issues. The next one is stereotypic movement disorder, and this includes head banging on a wall or a solid form, shaking or waving hands, often for no purpose or reason, rocking back and forth, nail biting, hitting self, or biting of self. The next one we have is specific learning disorder. And this is also known as a learning disorder or learning disability. It's a neurodevelopmental disorder that begins during school age, but may not be recognized until adulthood. Learning disabilities affects one of three areas, so reading, writing, and or math. Individuals affected by this disorder have academic skills that are well below average for their age. Can also occur in people who have been identified as intellectually gifted. Only manifests when the learning environment demands or assessment procedures pose barriers that are not overcome by their innate intelligence. These individuals produce lifelong impairments in activities depending on skills, so occupational performance. So there are severity levels for intellectual developmental disorder, and this is what we're going to talk about. And this is just to kind of give you guys an idea of what it looks like under each domain. Also in your DSM-5, and I will be providing you guys a note-friendly document with all of this in here. So you don't have to stress out too much to take notes for this lecture, as I've already composed it all for you. So we have for mild under the conceptual domain. So for adults, impairments include in areas such as executive function, cognitive flexibility, priority setting, strategizing and planning, short-term memory, and impairments to functional use of academic skills, including math, so money management and reading, minimal concrete approach to challenges and solutions compared to their age-related counterparts. Under the social domain, they have a limited understanding of the risks in their social surroundings. So social judgment is immature for their age. They are prone to gullibility and at risk for manipulation by others. Under the practical domain, in this domain, when individuals reach adulthood, they require support in areas such as grocery shopping, transportation, food preparation, home and child organizing, financial assistance, so money or banking. Generally, these individuals need support to make decisions, legal and healthcare, and support is typically needed to raise a family. Under the moderate column, we have, under conceptual domain, we have young children, typically in preschool, their language and pre-academic skills develop slowly compared to their age-related schoolmates. For school-age children, the process is understanding the concept of mathematics. Writing and reading occurs much slower than their peers throughout their academic journey. For the adults, in this area, their academic skills are at an elementary level, so they require ongoing support in a day-to-day life task. In some instances, people may take over the task permanently for the individual. So this is where you'll see caregivers. Under social domain, we have, so under this domain, people have difficulties perceiving or interpreting social cues accurately. They have limitations around social judgments and decision-making abilities, thus requiring caretakers to assist in these areas. Should individuals acquire a job, they need significant communicative and social support. Social limitations and communication are areas that are affected when with friendships for these individuals. Under practical domain, although an extended period of teaching is required and ongoing support for adults, they are able to accomplish and partake in household tasks. Independent employment is achievable for these individuals, but do require the support from their colleagues to navigate through complexities. Social expectations and other job-related responsibilities, so money management, health benefits, and scheduling, transportation. Maladaptive behaviors can show up, which can cause social issues. And then we move to the severe part. And so under conceptual domain, we have individuals in this area have a minimal understanding of written language or concepts involving numbers, mathematics, time, or measurements. Caretakers were needed to provide support in these areas. Under social domain, single words or phrases are used in their speech. Language is utilized for social communication instead of explanation. Individuals in this domain are able to understand simple speech and gestural communication. Interpersonal relations like family and familiar others are a source of help and support. Under practical, we have individuals in this area always require supervision. These individuals are not able to make any decisions for themselves or others regarding their well-being. They require assistance in environments such as home or community settings. Skills are acquired. Skills acquirement requires long-lasting teaching along with constant support. Maladaptive behaviors present for these individuals include injurious behaviors. And then we have profound. Remember, these domains we have individuals use certain visual spatial skills can be acquired. Skills such as matching or sorting based on characteristics. Finish with reading. Oh, those are my notes. And individuals express themselves largely through nonverbal and non-symbolic communication. To express emotions and desires, initiates and responds with gestural and emotional cues, experiences closeness and affection with caretakers, family members, or familiar people. Under practical domain, although the individual might be able to participate in some daily tasks, activities, so like hygiene, eating, or physical care, they still need the support and help from the caregivers and others. Individuals without ongoing high levels of support, like physical impairments, the individual is able to help out with some tasks at home, so like setting the dishes in the sink or feeding dogs. Co-occurring sensory or physical impairments are barriers that these individuals encounter with participation in recreational or vocational activities or environments. And then on to the neurocognitive disorders. Again, this is in your DSM-5. I will be going in order with these. So again, just you don't have to worry about taking too many notes because I will be supplying these for you. So, so an overview. So with the neurocognitive disorder, people will have reduced mental function, difficulties understanding language, behavior changes, challenges performing daily activities, primary affect learning, problem solving, memory and perception. Neurocognitive disorders can be classified as mild or major, varying on the severity of symptoms. Primary deficit of NCD is impaired cognition. So the first one we're going to talk about is delirium. And that is a disruption of consciousness and cognitive change that develop during a short time, reduce ability and attention, focus, direct, sustain, or shift. Most individuals affected by this recover with or without treatment, can progress to coma, seizures, stupor, or death in underlying condition if the underlying condition is unchecked or treated. Major and mild neurocognitive disorders. So major is the deterioration in cognitive functioning, which leads to decline in areas of social performance in at least one cognitive domain. So that'd be social, learning, memory, language, executive function. Perpetual learning can be with or without behavioral disturbances. And you have to specify the severity, so mild, moderate, or severe. For mild is moderate cognitive decline, no interfering with independence, not due to other mental disorders, not due to delirium, not better explained by a major psychiatric disorder, so major depressive disorder or schizophrenia. Major or mild neurocognitive disorder due to Alzheimer's disease. This one accounts for nearly half of neurocognitive disorders. Normally develops gradually and steadily, affects memory, orientation, judgment, and reasoning deficits. Other symptoms include depression and or anxiety, confusion, agitation, and combativeness. Then we have major or mild frontotemporal neurocognitive disorder. This is characterized by the deterioration of the brain tissue in the frontal and temporal lobes of a cerebral cortex, so thinning and shrinkage. Symptoms include social inappropriateness, loss of sympathy or empathy, apathy, or inertia. Major or mild neurocognitive disorder with Lewy bodies. It's an insidious onset and gradual progression, worsens over time. Memory loss and difficulty learning new information. Symptoms include delusions, restlessness, movement difficulties, motor impairment, speech difficulty, decreased attention, paranoia, confusion, and speech difficulties. This is actually what I'm sure, well, I think everybody knows who Robin Williams is. That was a comedian actor who was diagnosed with Lewy bodies. So this is what he had. Major or mild vascular neurocognitive disorder. So related to one or more cerebrovascular events, symptoms are not better explained by any other systemic disorder or brain disease. Behavioral symptoms include memory loss, slow thinking, depression, anxiety. Locomotor issues include slurred speech, often difficult to understand, gait disturbance, so that's like dizziness, vertigo, motion sickness, double vision, and autonomic dysfunction. Loss of executive function include problem solving, judgment, reasoning, and working memory. Major and mild neurocognitive disorders due to traumatic brain injury. Evidence of head trauma resulting from banging, shaking, cutting the brain, tissue from injury or assault, progressive dementia due to traumatic brain injury or result from multiple head traumas, and from a single blow or head trauma. Even one incident of head trauma can lead to psychological effects. If severe enough, it can lead to physical disability or death. Changes in personality following traumatic injury to the brain vary with the site and extent of injury, among other factors. So I kind of want to share something a little personal. So I actually had a TBI, traumatic brain injury, and I have a permanent disability, but you'll catch me repeating myself a lot in that when I had my accident, I ended up getting two concussions back to back. Literally, I had one, and then 2 days later, I had the second one. And so anything that I read, or if I study something, I have to read it a couple of times before I can retain it. I forget a lot of things. So it is extremely challenging when you have that and you're going to school, or even just day-to-day life. But just to kind of give you guys a little insight of what it's like. And this is just my experience. Obviously, it varies with other people, but it is definitely challenging. So moving on to the next one, substance medication-induced major or mild neurocognitive disorder. So this results from extended drug use, especially in combination with a poor diet, may be caused by alcohol, sedatives, hypnotic and anxiolytic or inhalant drugs. Brain damage may be permanent. Deficits include memory impairment and disturbed executive functioning. Major and mild neurocognitive disorders due to HIV infection. So this invades the central nervous system and causes minor or major neurocognitive disorder. Symptoms include forgetfulness, impaired concentration, or problem-solving ability. Then we have major or mild neurocognitive disorder due to prion disease, and this is a disorder of proteins in the brain that reproduce and cause damage. No treatment, so it's always fatal. Causes brain damage, which commonly results in a major neurocognitive disorder, so dementia. Prodromal symptoms include fatigue, anxiety, issues with appetite, sleeping, difficulties concentrating. Major or mild neurocognitive disorder due to Parkinson's disease. And this is characterized by the destruction or impairment of dopamine producing nerve cells in the substantia nigra, which is the black substance. It's an area that in the brain that helps regulate body movements. Symptoms include uncontrollable tremors, shaking, rigid muscles, and difficulty walking, tied to the deficiencies in the amount of dopamine in the brain. So not all with Parkinson's disease develop dementia. Then we have major cognitive due to Huntington's disease. This is a genetic degenerative disease that is characterized by jerking and twisting movements, mental deterioration, and unstable moods. Symptoms include involuntary movements, face, neck, limb, and trunk jerky movements. Differs from the movement of Parkinson's disease. Speech and swallowing difficulties, pain, fatigue, and difficulty sleeping, balance and mobility difficulties. There's a major and mild neurocognitive disorder due to another condition. So this is like criteria not met for a major or mild neurocognitive disorder. History of physical medical examination, so lab findings that neurocognitive disorder is a pathophysiological consequence of another medical condition. Then we have major or mild neurocognitive disorder due to multiple etiologies. So this is the clinical presentation of neurocognitive disorder for which there is evidence that multiple medical conditions exist. Unspecified neurocognitive disorder. So these are characteristics of a neurocognitive disorder that cause clinically significant distress or impairments in social, occupational, and other areas of functioning. Accurate etiology cannot be determined with adequate certainty to make an etiological attribution. So then we're going to move on to the domains. And so we have complex attention, which is, so unless unrestricted or simplified, the individual will have challenges paying attention. Thinking takes longer than usual. Thinking is easier when there's no competing stimuli present, so like music, TV, or other conversations. Then we move to example of assessments. So this is so a sustained attention, so you're able to identify tone, heard when prompted to identify. Under selective, we have selective attention is able to maintain attention despite competing stimuli. When it's divided, it's within same time attending two tasks at once. And then we move to executive function, which so relies on others to plan activities of daily living and make decisions. Effort required to complete several projects. Large social gatherings are more taxing and not enjoyable. Can only focus on one task at a time. And then when we move into the examples of assessments, so for planning, interpret sequential picture or object arrangement. Decision making, we have performance of tasks that assesses processes of deciding in the face of competing alternatives. For working memory, the person can hold information for a brief period. Under feedback and error, they're able to solve a problem from feedback. Overriding chooses complex, effortful solutions. Mental cognitive flexibility shifts between two concepts or tasks. Then we move on to learning and memory. So here we have, so the major part would be examples or symptoms of observation. So repeats themselves in a conversation, often within the same conversation. They cannot keep track of short lists of items when shopping or plans for the day. Requires frequent reminders to orient tasks at hand. If it's mild, they have difficulty recalling recent events and needs occasional reminders or rereading to keep track of characteristics in a movie or a novel. Loses track of whether bills or have already been paid. So except in severe forms of major neurocognitive disorder, semantic, autobiographical, and implicit memory are relatively preserved compared with recent memory. Some examples would be so like the immediate memory span. So they're able to repeat a list of words or numbers. For recent memory, they can assess and encode new information. So if the person's asked to recall as many words or diagrams or elements of a story as possible, they do cued recall. So examiner aids recall by providing semantic cues such as list all the foods item on a list or name all the children from the story. Then we move on to language, expressive language. So this is naming, word finding, fluency. So example of symptoms. So if it's major, they'll have difficulties with expressive or repetitive language. If it's severe impairment, they might not even recall the names or of close friends and family. If it's mild, they have noticeable word finding difficulties, so may substitute general for specific terms. Examples of assessment. So we have expressive language, confrontational naming. So this is like when they identify objects or pictures, fluency, name as many items as possible, and grammar and syntax. So errors observed during naming. Fluency tests are compared with norms to assess the frequency of errors and compare with the normal slips of the tongue. Repetitive language, so comprehension, word definition or object pointing tasks, so involved animate or inanimate stimuli. Then we're going to move to perceptual motor. So this includes, visual perception, visual constructional, perceptual motor praxis. So symptoms when they're major, they have challenges with previously familiar activities. So, using tools or driving a motor vehicle, navigating in familiar environments. Is often more confused at dusk when shadows and lowering levels of light change perceptions. If it's mild, they may need to rely more on maps or others for directions. Needs to expend greater effort for spatial tasks, so like assembly, sewing, knitting, and some examples of assessment include for or laptop. So visual perception, so line bisection tasks can be used to detect basic visual defect or attentional neglect. So that includes facial recognition, identification of figures or matching figures. The visual constructional, so that's assembly of items requiring hand-eye coordination. So copying or block assembly or drawing. Then perceptual motor, which is integrating perception with purposeful movement. So, inserting blocks into a board, or pegs. So we have praxis, which is the integrity of learned movements. So basically the ability to imitate gestures. So, maybe waving goodbye, or show me how you would use scissors, or show me how you would use a hammer. Gnosis, so perceptual integrity of awareness and recognition. So that's the recognition of faces or colors. And then we move on to the last part, which is social cognition. So this is the recognition of emotions. If it's major, it's behavior is it's clearly out of acceptable social range. So, they tend to show insensitivity to social standards, focuses excessively on a topic despite groups' disinterest or direct feedback, typically has little insight into these changes. It's mild, has subtle changes in behavior, attitude, often described as a change in personality. So it's such less ability to recognize social cues or read facial expressions. Then we move on to the example of assessments. And so recognition of emotion, so identification of emotion in images of faces representing a variety of both positive and negative emotions. Theory of mind, so ability to consider another person's mental state, questions to elicit information about the mental state of the individuals portrayed. So where will the girl look for the lost bag, or why is this boy sad? And that is it. That was just an overview of neurocognitive and neurodevelopmental disorders, depending on, you'll see this depending on your practicum site, if you decide if you want to work in these areas. Some practicum sites do specialize in, working with these types of disorders. And again, it's very straightforward. It's in your DSM-5. So I hope I didn't hope I didn't get too nervous with this presentation. But I didn't want to cover so much in giving you all, 15, 20 slides, because it's just very very clear cut in the DSM, and it's only so much you can go through each disorder, and then some of them you'll start to see that they kind of not overlap, but you'll see some similarities in these disorders with one another. And I will be uploading the notes. If you the notes and the PowerPoint. So if anybody has any questions, just shoot me an email. And thank you all for listening.